Oh, good evening, everyone. If I could just get a quick sound check in the chat box. All good, thank you very much. That's perfect. I'm glad you can hear me. So welcome along. I hope you're all well, and thanks for joining us at the new time of 7:30 on a Wednesday. So that's just to fit around our schedule. So I do apologise for having to change this webinar a few times. We've been just insanely busy over the last couple of weeks, both of us. So and I was unwell last week, so it all just went a bit wrong. So we're here at last. So thanks for bearing with us, and I hope tonight's worth the wait. So lots of new faces again this evening. So that's great to see. So welcome along to those of you that have never been here before. We're STC Training Solutions. We are a training provider based in the southeast of England with a base in Aylesbury. We predominantly deliver FREC 3 and FREC 4 programs, and we came up with this idea of doing some online CPD about a year and a half ago, actually, with the first lockdown, and it's kind of gone from there. So this is a series about subjects that might help those of you doing FREC 4 and beyond, those of you that have already done your certificates and want some refresher, and of course anyone out there that just has a general interest in this type of stuff. So hopefully we can point you in the right direction if any of you are looking for courses. So my name's Ines. I'm a paramedic practitioner by trade. I used to work for a couple of the ambulance services full-time down here in the southeast of England. I now work full-time in a GP surgery and just do bank work to try and keep up to date with everything that's going on in emergency medicine out on the road. As I say, we're here for the next hour or so this evening. So if you've got any questions as we go along, then please do ask. It's good to see a nice crowd this evening. We do want it to be as interactive as possible. So I've just realised the chat's disappeared. Fantastic! Wow, we've got a very an international audience again. So thanks everyone for joining us. So Orkney, well done. Nice to see you again, Paul. And we have Fiji, Malaysia. Wow, fantastic. Welcome along, guys. So we will so it's just gone at 7:30. So anyone that wants to join in, and Qatar as well. Well, fantastic. Okay. So let's get going then. So we want tonight to be as interactive as possible. So we as I say, pop any questions you've got as you go along in the chat, and you can also call, text us, or tweet us during or after the event if there's anything you want to ask. Matt, hi. Very, very glamorous Manchester there. Very exotic location. So as I say, predominantly we are a FREC training provider. We have FREC 3 and FREC 4 courses coming up in the next few months. Just bear in mind, our FREC 3 courses are selling out really quickly at the moment, which is great. But if you are interested in doing FREC 3, there are only a few spaces left now this year. So we'll be looking at January and February time fairly soon. If that's something that interests you, do get booked in. We still have spaces on our weekend FREC 3 course starting on the 20th of November. That's the last weekend course before Christmas. And the last Monday to Friday course before Christmas is the 6th of December, which still has space. Those of you that have done your FREC 3 want to move up to FREC 4, then please do come and join us. We've got a course starting on the 30th of October over weekends. We advise that one for people who are new to the industry. Those that have some experience are more than welcome to have a go at the Monday to Friday version of the FREC 4, although it is a lot more intense. So both of those courses on the screen there have spaces still available. ILS, we've got one coming up on the 17th of October. Those of you with FREC 4, FREC 5, or another healthcare professional that want to keep up to date, then come and join us in Aylesbury on the 17th for just £95. And Safe Administration Life-Saving Meds, always a popular course, so much so that we have sold out for the rest of the year. So 15th of January is the next course with space, but that has been very popular, so that's going to be filling up in the next few days, I should imagine. So onwards, that's enough of the plug. So on to the free stuff. So this is the series so far. We've talked about CPD requirements of the FREC 4 and FREC 4. We are going to update that webinar at some stage because the CPD requirements have changed quite significantly in the last few months. So since we made that webinar, so that's going to be updated. Anatomy and physiology, common pathophysiology, we finished talking about last week, and now we're on to a new subject, which is maternity care. You'll see that next week we have on the menu some patient assessment followed by some paediatric assessment the week after. We're going to talk about sepsis in some detail. We're going to talk through oxygen and Entonox guidelines. We're also going to do a session on ECG Basics for those of you working through FREC 4, because I know that's an area that our students seem to struggle with. And then we're going to talk about intermediate life support on a theory basis. Doesn't replace the need for you to do a full face-to-face course, though, if you are required to do so. So that's what's coming. And as I say, we will be remaking the CPD requirements video. Those of you that do have an interest in ECGs, they do have a look at our YouTube channel. We did an ECG series last year. And again, we are looking at refreshing that with some new material over the next 6 months or so. So tonight then we're going to look at the stages of labour. We're going to look at normal childbirth. We're going to look at some birth complications. By no means are we going to look at them all. We're going to look at a level that's appropriate to those of you that are looking to do FREC 4 or looking to move on from FREC 4. Neonatal life support, again, not covered in FREC 4, but it may be of interest to those of you that are looking at going up to FREC 5 or beyond. And we're going to be talking about how to assess the newborn infant, which is just the last little session at the end today. So, as I say, nice and interactive, please, guys. So do get in the chat. Do ask questions. We're going to be using Mentimeter again this evening, as usual. So do get your smartphones ready. We've got a quiz lined up, so there will be an overall winner at the end of the evening. So yes, absolutely. So if you just do get involved in those, the more people that get onto those quizzes, the better. It's a timed one this evening. As I say, the first person to answer correctly wins the most points, and then at the end of the evening, one of you will have the most points. Okie dokie. So there we go then. So recommended reading, those of you that are looking at some books to read. I know I like a good book for subjects like this. I mean, I can't recommend Emergency Birth in the Community enough. It's only a little book. It's a little pocket-sized book, small, well, kind of same size as JLCAT pocketbook, written by one of our consultant midwives at the London Ambulance Service, Amanda Mansfield, who is absolutely fantastic. And anything I know about maternity is thanks to her. So we have so absolutely, if this is a subject that interests you, or you are working in a situation already where emergency birth might be something that you need to deal with, then I can't recommend that textbook enough. It's a little pocket book more than a textbook. Of course, that feeds off the JL Calc main textbook, which of course is a little bit out of date now, but the maternity section hasn't really changed. Ambulance care essentials and ambulance care practice, of course, are the staple for FREC students. So if you haven't been provided one by your course provider, then do get in touch. We can always get one sent over to you. So the stages of labour then. Okay. What I'm going to do is just flick back. We have the first technical glitch of the evening. So I'm going to go over to Mentimeter. So menti.com. If you grab your smartphones now, put in the code at the top. So go to menti.com, put the code in of 70150961. Excellent, good. There are some people joining. I'll give you just a few minutes just to join up. Okay. We're looking for as many of you as possible to join. There's 55 of you on the chat at the moment, so let's get at least half of you in there. So we're going to answer 8 questions this evening as the slides go through. So just give you a few minutes just for the rest of you to get in there. So if you want to take part in this evening's quiz, then do get involved now. Grab your smartphone, menti.com, and put the code in 70150961. Fantastic. Okie dokie. So you can, of course, continue to join once the quiz starts, but of course you lose the chance at getting the highest number of points for the first question. So, okay, I'm going to start the countdown then. So you have to answer first to get the most points. There's going to be a question on the screen, which is, when does stage 1 of labour end? When does stage 1 of labour end? So you've got 4 options: with the delivery of the placenta at 10 centimeters even, dilation, following rupture of the membranes, or with delivery of the infant. So here you go. Time's up. Most of you going for B, which of course is correct. Okay, let's see who was the quickest. Okay, it's fairly close there, isn't it? CR, whoever you are, and Sinead, Lee are the top three there. Okay, well done. So it should, in theory, if the system is working properly, it should remember you, and we should see how we get on over the next few questions. So fantastic, that was the correct answer. So let's head back then to the stages of labour. Here we go. So those of you that saw the answer very quickly, first technical glitch, have to bear that in mind. So the stages of labour then. So we have three stages. Stage one starts with the onset of regular contractions. And of course, that's sometimes a bit of a judgment call as to what constitutes regular contractions. I would certainly say once there's some pattern starting to, and we're starting to feel the need to you know, or the mum is telling you that things are happening, that's certainly a fairly good pointer. So there's no time as such as what constitutes regular contractions, but of course you may be aware of the term that once the contractions are about 2 minutes apart, you probably don't have time to get to hospital. So it's at some point, you know, between that you need to make a decision of do you stay or do you take them to hospital and deliver there instead. So a lot will depend on how far you are from hospital and what complications are predicted, of course. So stage one of labour starts with the onset of regular contractions, and that ends, as you've just correctly answered, at 10 centimetres of dilation of the cervix. Okay, and that's at the point at which the baby's head can engage with the birth canal and start its process of birth. Which of course is stage two. Stage two is from engagement of the head, so the head entering the birth canal, and that finishes with complete delivery of the infant. Okay, and then stage three, as you can see, that ends with delivery of the placenta or the afterbirth. That is stage three of labour. So clearly, stage one is arguably the most the least time pressured from our point of view. I would suggest, of course, there's going to be an element of pain management we need to do for mum during that time, and of course our decision making around at what point are we going to hospital. Now, of course, with first time mums, stage one of labour can last 4 days. And of course, the labour wards are all very, very busy. So it's not uncommon nowadays that we get involved because mum's been, you know, phoning the labour ward and been in and been assessed and sent home, and been in and been assessed and sent home. And then, you know, not wanting to get it wrong again, leaves it too late and to the point where she's having very regular contractions and an ambulance has to be called and we deliver at home. So that's not an uncommon scenario in the UK. Of course, you know, the time that takes is very, very unpredictable actually. But of course, the more children that mum has had, the faster stage one is generally going to progress. And of course, we want to try and capture the patients that are going to have complicated birth for a variety of reasons. If some of the complications we're going to talk about this evening have been identified earlier in antenatal, we would ideally want those patients to deliver in hospital anyway. So plans would be to admit them well before they start labour, or indeed to induce them, or indeed to have C-section. So stage two of labour is the busiest for us as an ambulance crew. If you're dealing with this, obviously there's a lot to think about, there's a lot to do, but actually you don't really need to well, your mind is certainly going round and round in circles, and there's probably lots of equipment that you're preparing, but in terms of assisting the baby, there's very, very little that we need to do. Babies do deliver themselves very happily in most situations. It's just pain relief for mum and monitoring for any of the emergencies that a few of which we're going to talk about this evening. And then of course stage three is delivery of the placenta. It's still a painful process, so don't forget pain relief during that stage. And of course, we want to make sure that the placenta delivers completely and delivers within a reasonable amount of time, and that's where the midwives are going to be important. Whether you can get a community midwife to you, or whether you need to then take the patient to a maternity reception area for them assess that. Okay, so generally speaking, things go fairly well with maternity. I've dealt with a good number now, and very much in the minority when things are going wrong. That, of course, by statistically speaking, the ambulance service is much more likely to get involved when things are going wrong, of course, aren't they? So we do have to just kind of bear that in mind. So that's what we mean by the stages of labour. Well, you'll hear this term of normal vaginal delivery. That just is effectively the baby is delivering through the vagina as it was all designed to. The other option is C-section. Of course, there are forceps and etc. different types of delivery that take place through the vagina, but normal unassisted vaginal delivery is what most people are aiming for, but of course planned C-sections are increasing. So with before engagement there in section 1 is usually during the first stage of labour as the cervix is dilating. I did forget to mention just in that picture there, the rupture of membranes that's happening in the middle left picture there. You can see some fluid leaving the vagina. That's the spontaneous rupture of membranes, or SROM, S-R-O-M. That can take place at any point during stage 1 or stage 2 of labour, and actually some babies are born within the sac, and that sac has to be ruptured after stage 2, but the rupture of membranes can happen at any point and doesn't actually give you a huge amount of information about when birth is expected to happen. Early SROM doesn't necessarily mean the labour is going to be quick. Likewise, if you can have very, very quick deliveries and not have SROM until pushing well into stage 2. Good. So there's a few stages of the baby. Ideally now for us to have a normal presentation birth, and we're going to talk about some abnormal lies very shortly, but to have a normal presentation birth, we're looking for that kind of initial descent and that internal rotation in figure 3, where where baby's face turns to the posterior, mum's posterior, and then starts to deliver, and we expect to see the top of the head presenting at the vagina as mum starts to push, and that's called crowning. Crowning is when the let's say the baby's head, often with hair, is visible. We'll talk about what happens if we see anything other than the top of the baby's head very shortly. As you can see there, as baby is delivered, they have a tendency just to twist clockwise by about 90 degrees, and that's just to assist with getting the shoulders through the pelvis. We will talk about a problem involving shoulders getting stuck fairly shortly, but shoulder dystocia, and that's at the point at which that becomes an issue. And we'll talk about some manoeuvres that you can, as FREC 4 anyway, administer if you're ever stuck in this situation. So good. So that's the normal kind of delivery, as I say, face down, and then we rotate slightly clockwise from how we're looking at it, slightly clockwise. So the baby's face ends up pointing off to mum's right thigh. Excellent. So the process of normal childbirth. So this is from an ambulance point of view. So obviously in hospital things are in some areas slightly different, but the general principles are the same. And that is, of course, the temperature of the baby is really, really important. I can't off the top of my head remember the statistic now. I had a really good statistic a few months ago somebody told me about, in terms of temperature drop versus mortality, and it's actually really scary. So I think a degree drop in patients in the infant's body temperature after birth is something like 50% mortality. It's something insane like that. So you have to really keep the baby as warm as possible. So of course, getting the environment warm and getting some equipment prepared. So all ambulance services carry maternity packs. I dare say a lot of the private companies do as well, certainly those that are likely to deal with these situations. But it's worth familiarising yourself with your maternity kit. Within there, there's going to be some nice warm blankets that you can wrap baby up in, or we have the little baby grows, or the little kind of hoods that go over the head, and then you wrap the body up. You get one to dry them off, and then another nice one to wrap them up in, so they're in nice dry towel for breastfeeding and whatever else goes on after birth. So as I say, preparing all equipment, so that's going to be your maternity kit, making sure you know where everything is, but unfortunately it does also mean preparing a bit of a resuscitation station. We are going to talk about NLS neonate life support just at the end before we go. But it is a bit of it's one of those areas you should always have it ready. You never know when you're going to need it. It's far better to have that laid out discreetly. So when things don't quite go to plan, that you have everything to hand. There's nothing worse than chucking the bags around all over the place, trying to find the bit of kit that you need. Just lay it out if you have time, of course. Many a time I've turned up at birth imminent and they weren't kidding. You walk in the door and there's the baby's head. So you don't have a chance to get the Entonox out, let alone any of the equipment you want. It's catch and hope everything goes well. That's the nature of the job, though, isn't it? If you do have time, was it the 7 Ps? Poor planning equals poor performance. So making sure you have all your equipment ready. And don't forget, that includes mum too. So there is the risk to mum of significant bleeding after birth. And so it's not just baby that you might be resuscitating, it might be mum instead, or as well as mum. That's not been unheard of. That's a pretty awful situation to be in. And of course, one of the parts that we need to make sure is ensuring you have the sufficient resources available. So ambulance service guidelines are that you have an ambulance for mum and an ambulance for baby. Now, that is just in case the worst happens. Obviously, you're not going to separate them. You're not going to take baby in one ambulance and mum in another. But ultimately, if they're both peri-arrest, then actually you may have to. So that's why we do request 2 crews, so, as a minimum for a birth. Obviously, if you've got multiple births, as we'll talk about in a sec, 1 crew per patient or potential patient. Dignity. Okay, so I can think the last baby I delivered was at the side of the A4 in Hounslow, of all places. So not very dignified at all. Very public, very exposed, and unfortunately we had legs facing towards the traffic. So I don't know how we didn't cause a massive pile-up. But it's sometimes easier said than done. Maintaining dignity during childbirth is something we should try to do. Clearly, the vast majority, I dare say, you'll get to as an ambulance crew will be in a patient's house, which is, they may not be that bothered about their dignity at that point if it's only people they know around them. But out in the public, it does happen. So I've done a few childbirths in public places, and trying to maintain dignity is very difficult, but should still be considered without hindering your progress, particularly if things are going wrong. Of course, it's exactly the same way as fitting and cardiac arrest and things like that. It's doing your best, considering how nosy the general public can be. So, and everything ends up on YouTube nowadays, doesn't it? So, only encourage pushing when the head is visible. That's for us as relatively untrained operators in this case. It's maternity training in the ambulance services is better, much better than it used to be, but still minimal. So we're only encouraging pushing once you can actually see the head being visible. The theory behind that is you don't want to rush, you don't want to push too fast, because that's when we get tearing, that's when we get shoulder dystocia, that's when we get lots of other problems. So tearing can lead to quite significant bleeding and lots of kind of other procedures that need to be done later. So not rushing the process, but at the same time recognizing when things aren't progressing quickly enough, which is something we'll come on to. Certainly us at the moment, we don't pull any part of the body. There's a very real risk of shoulder dislocations and so on and so forth. If you start pulling on arms and things like that. So babies will deliver naturally. Other than in shoulder dystocia, they generally don't need a huge amount of effort going on, which is something we'll talk about. That's at this level, I'll point out. Clearly midwives and obstetricians are going to be doing, following very, very different subject. No, it's a very different material, but for us, we're not pulling any part. Okay. Be ready to catch, absolutely. So babies are really slippery, aren't they? It's like trying to catch soap. It's really quite you don't be that person that drops the baby. I touch wood. I'm touching a lot of wood right now. I've never done it, but there's always a first time, isn't it? You don't want to be that person. So had some close calls, but don't drop babies. So just make sure you've got a nice soft landing for them. Generally speaking, once mum's pushing, we pop an incontinence pad underneath for a couple of reasons, but one is so that baby does have a bit of a soft landing, and then we get the blankets ready. So as soon as baby comes out, grab it with the blanket, rub, get it nice and dry, and then obviously get it into the dry baby grow and get it onto mum's skin to keep warm. So when we talk about rubbing them dry, we do talk about doing it quite vigorously. It's actually that stimulus now. They used to slap babies, didn't they, when they came out and they weren't breathing. Nowadays we replace that by vigorously drying. So I mean really giving them a good rub down, top to toe, wiping any mucus or stool or anything like that away from the mouth. and that should be enough stimulus for them to kind of wake up and start breathing if everything's gone okay. So and 99% of the time it does. That's also, as I say, stops any evaporation of the fluids on them, causing cooling. So obviously we're really focused on keeping mum warm. Sorry, we're really focused on keeping baby warm as absolutely much as possible. So direct onto mum's skin again for bonding, for oxytocin release, which is going to start the third stage of labour, and also to try and get onto breastfeeding. So keeping them warm and bonding and all that type of stuff are really good benefits of it. So skin to skin with mum, wrapped in a nice warm dry towel or whatever you have available in your kit, and ideally straight onto the nipple for breastfeeding. Early breastfeeding stimulates oxytocin, as I say, which starts the uterus contracting again and delivering the placenta. It speeds up the third stage of labour. Obviously, if mum's not breastfeeding, then nature takes its course. But ideally, that's what we want. And then, as I say, don't rush to cut the cord. So cutting the cord isn't technically taught on FREC 4, but it's one of those, I mean, generally speaking, because you're not going to be on your own for very long. If you are delivering on your own as a FREC 4, you would hope that an ambulance is on the way to you with a paramedic or technician on. So it's not taught on FREC 4, but if you are taught to cut the cord, there's no rush. Even if baby delivers and is completely flat and needs resuscitation, why cut the cord early? The cord is still connected to the placenta, which is still getting oxygen by diffusion through the cervix. Sorry, through the uterus. So why rush? Until that placenta actually detaches, that's still helping the baby. And of course, there's a significant amount of blood within the umbilical cord. So when you do come to cut it, of course, squeeze it towards the baby. Baby's born with about 240 ml of blood in their body. That's less, 2/3 of a can of Coke, isn't it? It's not a lot of blood at all. So make sure we're squeezing towards baby when you do come to cut, but don't rush. Absolutely don't rush to cut the cord. As I say, resuscitation now, best practice, if you do need to do NLS, is to resuscitate between mum's legs with the cord still attached. So wait for white is the term. So you'll see that when the cord comes, first of all, it's nice and purple, it's pulsing, it's clearly a live thing. After 5, 10, 15, it can be ages, it starts to slow down, and then eventually you'll see that it kind of goes opaque, it goes white, it goes fairly clear. That's the point at which to cut it. There's absolutely no rush before then, unless you're in hospital, obviously, and taking baby off to an incubator or blah, blah, blah. But pre-hospital, absolutely no rush. It's not going to change anything. Resuscitate baby between mum's legs if we have to do that. Okay. So we're going to talk a little bit about premature birth. So there's a few dates just to know. Obviously, full term is 38 weeks or 38. Well, it's 40 technically, isn't it, by the book? So 38 weeks and above is considered to be full term. Less than 20 weeks is not compatible with life. So a fetus born before 20 weeks is not viable, and no resuscitation attempt need be undertaken. I mean, that is an incredibly small fetus. So we don't have the equipment to resuscitate that in any case. 20 to 24 weeks is this little bit of a grey area around resuscitation attempts. So if the fetus makes no attempt at breathing, if there's no signs of life, then no resuscitation is attempted. If you do see breathing, if you do see signs of life or attempts at breathing, should I say, or any hint of a sign of life, then we do make a resuscitation effort on a 20 to 24 week fetus is the current guidance. So 25 weeks onwards, it is normal procedure. So it's normal neonatal life support from then on. So there's a very difficult decision to make there, isn't there? 20 to 24 weeks, that's going to be truly horrific for mum and everyone else involved. So clearly that's going to be a very difficult decision that may not be easily made. But if the guidance suggests anyway, if the baby does not make any effort, then survival is next to nothing. So resuscitation attempts are not attempted in those cases. All right. Obviously not a nice scenario to be in. And obviously 38 weeks onwards, they are normal. They are a normal full-term baby and shouldn't need resuscitation. The earlier you get towards 25 weeks, the more likely you are to have to resuscitate a newborn infant, more just because of poorly developed lungs and they're in the world sooner than they would have liked. So So multiple births scare people. I can see why. So ideally, we want multiple births to be delivered in hospital. There's a high rate of complications associated with them, so certainly much higher than single births. Consider whether there is time to transport between one baby and another. Unless you're lucky, you're in London, you're very close to a maternity unit. That's probably not going to be the case, but it is something in the guidance. So it's considering that move between hospital. So those of you that have worked in the ambulance service at all would have probably heard the phrase "nobody's born and nobody dies on my ambulance." That's generally a good thing. Nobody's born on the ambulance because it's cold and drafty and cramped, and actually trying to deliver. I have done it. I have delivered babies on ambulances, and I can testify that it's much more difficult than trying to deliver safely at home or obviously in a purpose-defined birthing unit. Nobody dies on the ambulance because of coroner's rules. So there's two reasons there. So, but that's something we don't want to happen. So you've got to consider: do you have time to get mum to hospital before second infant? So each birth is managed individually. Each birth is treated normally. It's almost inevitable. One of them is going to be a breech presentation. We'll talk about that shortly. And it is likely that one or both will need some resuscitation because they are premature. So just making sure you've got plenty of resources there. Don't forget, it's one ambulance per patient. There you go, and mum is included as a patient. So if you've got twins, 3 ambulances. If you've got triplets, 4 ambulances. Okay, don't bother having quads. There aren't enough ambulances in the UK for that. So it seems at the moment, if you follow any of their Facebook pages, they're in meltdown, aren't they? So as we say, their labour is likely to be premature. Complications are common, but complications being, one of the babies comes out and needs a bit of resuscitation help, or one of them comes out. Well, one of them will come out breech. So lots to contend with multiple births. Hence why we try not to let them have their babies in the community. I've only dealt with one multiple birth in the community. It was absolutely fine, but it was a lot of work. And again, you can see why people get a bit nervous about that. So we're going to talk about some abnormal presentations. So I am going to ask you another question. So let's head back to menti.com. Those of you that sign up to the quiz, grab your smartphones and get going again then. So we have another question. When everybody's ready, I shall start the countdown. I think you can rejoin, or you can join if you didn't join for the first one. Yeah, I've seen the number go up, so obviously you can. So you can join back in if you want. So I'm going to press enter to start the countdown. Okay, anyone else want to join 20? Anyone else want to join in on the quiz? Excellent. Okay, right. So you'll have 20 seconds to answer again. And the fastest one wins points. Which of the following birth presentations will deliver normally? Face presentation. Oh, hang on. Right, ignore that. It clearly hasn't saved. Put it in the chat, guys. So which of the, so the answer should have been a face presentation. I'm going to see what's happened there. None of them are correct. What's it going to say? None of these options are correct. Good. Okay, technology, move on. Right, the question was going to be, or the answers were supposed to be face presentation, footling breech, and oh no, it's disappeared off my note screen as well. Don't worry, ignore that one. We'll come back to another one. Okay. Technology is having fun this evening. So there are some different presentations that you may see. Now, normal cephalic or cephalic presentation is prior to engagement. So as the baby's head engages, clearly they engage facing backwards and you see the top of the head. That's normal presentation. What you can sometimes get, very rarely, is a face presentation. So rather than the chin being tucked down into the baby's chest, you get the face of the baby presenting at the vagina as mum starts to push. Now, they rarely deliver. Okay, face presentations don't normally deliver. So that's going to be a kind of rapid transport into a birth unit. They may well into a labour ward. So they may well need C-section. Unfortunately, if you see these abnormal presentations that won't deliver outside of hospital, unfortunately, it's a bit of a ticking time, isn't it? You've got to get to a birth unit as quickly as possible in order to get them a C-section and for it to be viable. So it's quite a stressful situation to be in. I've talked about breech presentations. So breech presentations, as you see there, second from the left, are relatively common, certainly with multiple births. And that is where you see baby's bum as the first presentation. So you see a bum coming out of a vagina. So it's not it's a bit of a bizarre sight when you first see it. You start to think, what on earth's going on? But actually, you fairly quickly realise it's a breech presentation. Now, one of the complications of a breech presentation is something called a footling breech, which is when one or both of the feet protrude from the vagina before the baby descends through the birth canal. Now, unfortunately, it does depend on the positioning of the baby whether or not that's going to deliver, and you're not going to know that. And that is a specialist skill to try and get that baby out. And again, may result in an emergency C-section. So the only place that patient needs to be is in hospital. Again, unfortunately, if you see this presentation out of hospital and a million miles away from the nearest birthing unit, it's a bit of a disheartening thing to see, but it may deliver, but it's very, very unlikely to. So normal breech presentations, deliver as normal. So the bum will start to deliver. Eventually, the legs will drop down one by one, then the arms will drop down one by one, and then you'll deliver the head. So the only point at which we touch a breech presentation is that the point at which the head starts to deliver. The reason we do that, your stimulus, your touch on the baby could cause the baby to breathe. The baby's head is obviously still within the cervix, and clearly that's not going to end terribly well if you stimulate that too early. So with normal birth, of course, if the baby starts to breathe as the face is delivered or as the head is delivered, that's absolutely fine. That's great. We don't want that happening when they are breech presenting. So you have a couple of lies there: oblique lie and transverse lie. They won't deliver if mum's in established labour and the baby is not in the right position. We're not going to know that. So they're the two that they're kind of nice to know, but transverse lie and oblique lie, you're not going to know that baby's in that position unless you've been taught to examine the pregnant abdomen properly. Not something you should do without training, I should add, or if it's in the patient's notes, but in which case they should be in hospital anyway and delivering there, probably with C-section again. So the one that will deliver is the standard breech. If you see a foot popping out, it probably won't deliver. And if you see the face, very rare, but that probably won't deliver either. So normal and full and standard breech will deliver absolutely fine. Just with breech, don't touch baby until the head is delivering, because you don't want to stimulate breath too soon. Brilliant. Apologies for the technology there. I don't quite know why that didn't save. So right. So we're back to. It's all frozen. Okay, we're back to menti.com. Let's give it a go. So back to menti.com 70150961. The leaderboard's unchanged because the last one didn't count. So question 3 of 8. If anyone else wants to jump in, now is the time. I'll start the timer very shortly. 20 seconds to answer. Menti.com 70150961. 20 seconds. What is a cord prolapse? A, B, C, or D? The umbilical cord being visible outside the vagina, blood loss from a low-lying placenta, a cord that doesn't pulse after delivery, or a cord that ruptures during delivery. Good, perfect, well done. 15 of you getting the right answer there. Let's see who is at the top of the leaderboard now. Okay. So Sinead took the lead there, but CR, whoever you are, is still doing very well. Sinead's in the lead. Well done. Well done. Perfect. So some good scores there. I like it. You're obviously answering very, very quickly. So perfect. Let's go back then. So cord prolapse. So when the cord drops below and presents through the vagina, basically. So this can happen during stage one. It can happen prior to stage one of labour in theory. This generally occurs during stage one. And you'll see when you examine mum, she'll say that she can feel something down there and doesn't feel quite right. You examine mum, you see the umbilical cord poking out from the vagina. Okay, it is absolutely, let's just be clear, this is a time critical emergency. Okay, mum cannot be allowed to start pushing as the baby descends down the birth canal. That's going to occlude the cord, and that's going to have an awful outcome. So now, unfortunately, again, if you're a long way from hospital, the chances of this having a good outcome are slim, but this is an absolute, one of the most time critical emergencies you're going to come across in maternity. So there are a few things that can cause this, but it tends to be a bit of it's rare, thankfully, but it tends to be just one of those things that's happened. But I seem to recall that small mum with a large baby, or low amniotic fluid levels can also contribute, as can multiple previous births could also contribute to it. So, but again, sometimes it just happens, and there's no kind of rhyme or reason to it. But either way, it's not a good thing to see in hospital. That would be emergency C-section. Okay, there's different teaching depending on which level you are. There are some clinicians that will be taught to replace the cord within the vagina, and then to use a dry dressing. Depending on what you are taught and what your company allows you to do, obviously follow your local guidance. But generally speaking, we need to be aware that the cord could spasm at any time. So keeping it nice and warm and shielded from kind of drafts and things like that is going to be important. As I say, during second stage of labour, it's all going to go wrong. So we really don't want to progress to that point if we can help it. Straight to hospital. We don't want to do any direct pressure on the cord. So this management here is written for FREC 4 students. If you have been trained to a higher level and you are allowed to replace the cord, then obviously that would be the next step. Replace the cord and then normally apply a dry dressing or a big old sanitary towel underneath, just to try and keep it dry. We can get the patient to walk. In fact, the patient should walk because it's quicker than carrying them and things like that. So we should get them on the ambulance as quickly as possible, but don't allow them to sit down. So no sitting them on carry chairs and things like that. And then we don't lie flat on our back with third trimester pregnancy because of the inferior vena cava being squashed. So we want to raise the right hip slightly. We want to put them in what we call the exaggerated left lateral tilt. So wedge something under mum's right hip. And pop off to hospital. It used to be back in the day they would put them in the all fours position, but clearly that's not safe to transport someone in all fours on a stretcher. But all fours position is fine for kind of temporary, right, wait there while I get this ready type of thing. But standing is fine as well. Just no sitting. Don't sit on the cord. You'll occlude it or cause it to spasm, and obviously don't lie on her back. So shoulder dystocia. Shoulder dystocia is one of those scary ones. I think that everybody that's been trained in any kind of maternity is fearful of, and I've dealt with a couple. They are exceptionally stressful times. I often tell the story. My most stressful one was at a flat in southwest London, and with a mum that didn't speak very much English, and her husband was at work, was desperately trying to get home. She was delivering, and we ended up with shoulder dystocia. So it was me and mum, and I remember getting the neighbour in to help because my ambulance was still a good few minutes away. So getting the neighbour, neighbour had never met this lady. Neighbour didn't speak very much English either. It was a bit of, you could do with Carry On music in the background or a bit of Benny Hill music in the background, but all's well that ends well. It worked very well, and we had a healthy boy, but he was a big baby and a small mum, and we had a shoulder dystocia. So shoulder dystocia is where the anterior shoulder, so the shoulder that's forward most in mum's body, is wedged under the pubic bone. Okay, or wedged behind the pubic bone, should I say? As I say, small mum, big baby is the classic combination. You undergo a risk assessment for shoulder dystocia, I believe, before when you're kind of making your birthing plan and so on and so forth. And they do try and kind of get in there with the ones that are really high risk. But the principle is that we need to fairly rapidly identify shoulder dystocia and do something about it. So we have what's called the McRoberts position. The McRoberts position is basically knees as close to the chest as possible and spread wide apart. Okay, and what that does is it opens the gap within the pelvis and should just allow that anterior shoulder to pass. If that doesn't work, we do suprapubic pressure, so just above the pubic bone. We're going to put some pressure, we're going to feel for the anterior shoulder of the baby, and we're going to push down. That's the only time we ever use any force, certainly as FREC 4 anyway, that's the only time we're ever allowed to use any force when delivering a baby, and that's to get mum's knees back to her chest, up in the air, legs apart, and push down on the just above the pubic bone. It's a very undignified position, but at the end of the day, we need to get that baby out. Okay, the problem with the shoulder dystocia, if you do allow it to proceed for too long, is that baby becomes hypoxic. Baby isn't getting a great blood supply whilst they're going through the birth canal. Obviously, the cord is likely to start being compressed. And apart from anything else, they can't breathe, they can't do a whole lot at that point. So babies do become distressed fairly quickly. Now nature allows for this and has different stages of apnea that the child goes through, but of course we don't want that to go on any longer than we have to. So we need to identify shoulder dystocia and get that child moving fairly quickly. So I'm going to ask you another question. Back to menti.com, see how many know the answer. So the next question is going to be, I'll let any of you that want to join, there you go, get back on to menti.com 70150961 if you do want to join afresh. And there we go, we're back up to the 20 that started last time. Question 4 is going to be, how long should you wait before treating for shoulder dystocia? 1 minute, 5 minutes, 5 contractions or 2 contractions? How long should you wait before treating for shoulder dystocia? Brilliant. Okay, excellent. So there you go, 2 contractions. Fantastic. So it's what it used to be. It used to be in time. It used to be done in 2 minutes, every 2 minutes. If you haven't seen, if we've had contractions and the baby hasn't moved for 2 minutes, we start for shoulder dystocia. It's now 2 unsuccessful contractions, if you want to think of it that way. So you see baby's head appear, it's get crowns, so all looks good, all looks normal, and you expect with the next push that the baby's head is going to advance or maybe even deliver. Okay, that's the point at which we're starting this. So once you see crowning, if you see 2 contractions after the baby crowns and the head does not advance by any margin, then we are going to treat for shoulder dystocia. Now, you do also see something called turtlenecking, which is the baby's head may present, and then after the contraction ends, it pops back in, a bit like you get a bit of a turtleneck from the walls of the vagina, kind of cupping around the base of the head. So the head pops out, pops back in. It's called turtlenecking. It is a classic sign of shoulder dystocia. But when we start treating, there's two failed contractions after the baby's head presents. Okay, so fairly rapidly, those 2 contractions are going to be less than 2 minutes, more than likely. But it used to be 2 minutes in the old guidance. So yeah, fantastic. Let's see who answered that correctly most quickly. So, oh, not Sinead. Where's she gone? Okay. Here we go. Matt has taken the lead. Fantastic. Well done. Very quick, obviously, Matt. Well done, you. So, okay. All right, let's go back to our treatment here. So it absolutely can become a time-critical emergency. If you can't clear a shoulder dystocia, we absolutely have to run for hospital. But again, unfortunately, it's the longer the journey, the less likely that is to be a favourable outcome. So once the baby does not deliver after 2 contractions, we go into the McRoberts position, which is knees back, legs apart, and then we're going to do some suprapubic pressure.
I don't know that one.
Sorry, Alexa decided to pipe up there. So we do some suprapubic pressure as the picture decided there. So we can do just one direct pressure on top of the anterior shoulder, pushing it down and allowing it to pass, or we can do some rocking as well. So almost like CPR, but not quite as vicious. If we don't get the baby to deliver after trying McRoberts position and suprapubic pressure, we're going to start moving to hospital. Absolutely encourage a mum to walk. Okay, it reminds me of a very funny scenario with my very quick thinking crewmate. Well, preemptive crewmate decided to put a towel between mum's legs as we were walking mum down a small flight of stairs, and of course it was at that moment that baby decided to deliver after a shoulder dystocia. So delivered into the towel, thankfully. There were one standing in front, one standing behind holding this towel, and the baby delivered into the towel, thankfully, rather than onto the concrete floor, which would have been slightly less appropriate. So, but there you go. Do be prepared that if you start mum walking, that might just be the motion that's enough to free that anterior shoulder, and down the baby comes, because that's the last point that's holding it. You know, the tummy, the pelvis, the legs, they generally don't get held up very much once the head and shoulders are through. It's a fairly easy process. So again, we're going to use that exaggerated left lateral tilt position again, so we're not lying a heavily pregnant lady down on her inferior cava. Of course, we've got to be prepared for that baby to deliver at any point, so make sure you've got everything ready in the ambulance for if that does happen. You can use the all fours position as well. That used to be taught, so while we're preparing things, it's worth trying the all fours position. I have known that work. And certainly heard of many more times when it has. So McRoberts isn't the only position, but it is by far the most effective. So good McRoberts position with suprapubic pressure almost always sorts it. Into the all fours, get the patient to walk, get them on the ambulance, and then there we go. As I say, if you can't get the baby out, the longer you leave it, the less likely we are to have a good outcome there. So some of the other complications we're going to talk about are postpartum hemorrhage. So it is absolutely normal. There's often a lot of blood loss involved in bleeding. There's a lot of blood loss involved in childbirth. So it's quite normal to lose up to 500 ml. Okay, so up to 500 ml of blood can be lost. So and we need to try and identify the cause. Now there are a few causes of bleeding during childbirth, and of course, tearing is a real common one, and applying direct pressure. But the usual one, the most common one, is that the uterus hasn't contracted. So baby has delivered, placenta has detached, and the uterus hasn't contracted, and we've got a massive hemorrhage going on within the uterus. There's a few different ways of managing that, but generally we rub the top of the fundus, as it's called, to the top of the uterus. We rub that with a balled fist and try and get it to contract, and that often settles the blood down. Paramedics will give a medication called symptometrium, which tries to do the same thing chemically. But that good old rub, and of course there are some practitioners out there that will do bimanual compression just to really stem that flow. But that's the most common cause of significant postpartum hemorrhage. Of course, we've got to think about trauma. So if we've torn, we can just apply direct pressure in the usual way. And also we've got to think about, has mum got clotting disorders? But again, hopefully they would have been spotted in antenatal screening. So I'm going to ask a quick question just to see if anyone knows the answer. So next question. So jump back on, those of you that were on. There you go. Great stuff. I'm going to start the countdown timer. So the question is, which of the following is not one of the 4 T's of postpartum hemorrhage? So the 4 T's: tone, thrombin, tamponade, tissue. Which is not one of the 4 T's of postpartum hemorrhage? Time's up. Boom. Well done. Perfect. Tamponade is, of course, one of the 4 H's and T's of reversible causes of cardiac arrest. The others are 3 of the 4 T's that relate to postpartum hemorrhage. So very well done. Who's got the quickest fingers today? On this one, who are we looking at? Sinead, look at that. Sinead wasn't having any of that from Matt. So she's back in the lead, stamping her authority, and close in second place is CR and Grace. Well done. Perfect. Okay. So postpartum hemorrhage, there we go, the 4 T's. So tone, tissue, trauma, and thrombin. Tone is what I mean, tone of the uterus. Rubbing up a uterine contraction is often the way to stop postpartum hemorrhage from the uterus being baggy and saggy. Tissue is retained placenta. That's not uncommon to have a part of the placenta not deliver. That's why we get the placenta checked by the midwife. So that's why we need to retain the placenta after delivery in a clear plastic bag normally to be properly examined. Of course, the secondary problems with that are sepsis. So you can quite often get sepsis from after retained placenta. Trauma is tearing, trauma to the birth canal, direct pressure, just as you would with any other trauma. And thrombin is a problem with mum's inherent clotting. So, but again, hopefully should be highlighted at an antenatal stage, but again, there's not a huge amount we can do pre-hospital about that if mum's bleeding because of a clotting disorder. So good, okie dokie. So make sure the placenta is fully delivered, massage the fundus to encourage that contraction, direct pressure for trauma. Up to 500 ml is normal, okay, normally up in on our FREC 4 courses where we try and do some blood loss estimation. So 500 ml looks like an awful lot of blood, but that's normal, okay. Over 1 litre we become concerned, okay. Don't forget mum's blood volume increases by about 40% during the third trimester pregnancy. So she does have 40% more blood than another, a non-pregnant female. But of course, over 1 litre is still a significant amount that's going to start to have symptoms showing. Massive postpartum hemorrhage, you'll hear that term, is when mum has more than 50% of her blood loss, but at which point she's going to be peri-arrest, isn't she? And this is what I've said, you need to make sure you have enough crews for all your potential patients, and mum absolutely is a potential patient in a situation like this. So, perfect. So we're going to talk about neonatal life support now, folks, just before we wrap up for this evening. There is a warning. Neonatal life support does greatly differ from paediatric BLS, so standard paediatric BLS and ILS. So you do need to be aware that it should only be practiced by those of you that have been properly trained. So if you've done a FREC 4 course, you're not trained in neonatal life support. FREC 5 and onwards, really, technician level and paramedic level are trained at neonatal life support. If you're FREC 4 and you work in a company that is happy to support you through a neonatal life support course, then absolutely go and do one. It's fascinating stuff. And if you're in a position where this is likely to happen, then worth knowing. Okay, so we're going to talk about whoops, what have we got here? Why is it not working? There we go. So if in doubt, I've said to you, so anyone on a FREC 4 course that comes out, if you're not taught neonatal life support, the baby comes out and doesn't breathe, even if you are there as an event first aid, or even if you're there as a PCS ambulance, I don't know what situation you could be in. Just call 999 and say, look, I've not been trained in neonatal life support. They'll walk you through the process. They have a telephone kind of triage process in the same way as they talk the general public through CPR. So the following guidelines will only apply at the point of birth. So we have the phrase in the ambulance service of womb must be in the room. So when you hear womb in the room, that's what it means. So neonatal life support is only practiced on a baby that has just been born. Otherwise, it's just standard paediatric ILS. So, but do follow your applicable local guidance. Everywhere is slightly different on that rule. In hospital, slightly different. Some other ambulance trusts I know are slightly different. But neonatal life support is generally only practiced womb in the room. Baby's just been born. So I'm going to ask you a question. Okay. I think this is second to last question. No. Yeah. No, of course, there's a bonus question at the end. I forgot about that. Right, jump back on then, guys. So menti.com 70150961. Okay, there's your 20 back. Answer the fastest for me. So what's the correct ratio of CPR in neonatal life support? 32, 3-1, 15-2, 60-2. What are we going for? All vote now. Great. See what we all went for. Most of you going for 3-1, which is of course correct. Well done. So neonatal life support is very, very different. Okay, 3-1. Okay, and as you'll see shortly, as I walk you through neonatal life support, there's no rush to start chest compressions. That is absolutely not normally what baby needs. Okay, so fantastic. Well done to 9 of you. Obviously, I've had a little read around that. Let's see who answered the quickest. Where's Sinead? Okay, yeah. Is Sinead a midwife? Do we need to disqualify her? So no, very well done. Perfect. It's staying fairly close there, isn't it? Matt's been knocked off his post. So okie dokie, well done. Okay, let's come back. So there's some parts in red. So there's some general kind of golden rules here. Don't cut the cord too early. I've talked about that. All right, talked about why that's important. Don't allow the infant to get too cold. It's really difficult though to keep a baby warm on the floor, well, between mum's legs, or potentially on a floor when you're trying to do resuscitation. Okay, it's really quite difficult. So good ventilation is far more important than chest compressions. Okay, that's you'll see as we go through the process. And don't give oxygen unless a senior clinician tells you to. It's very rare that we use oxygen in neonate life support. It's all room air ventilation. If you've got a bag valve, you'll be an infant bag valve mask, or some do come in neonate sizes, not connected to oxygen. Okay, so just bear that in mind as we walk through the process. So dry the infant vigorously and keep them warm is clearly step one. Okay, that drying them vigorously is likely to stimulate some breath in an infant that is not completely flat. Okay, assessing Butch. I remember Butch being taught back on my technician course. I still use it. I haven't seen it written anywhere else since, but I'll credit the London Ambulance Service for this one. So Butch is breathing rates, umbilical cord, tone, colour, and heart rate. Really quite a useful little acronym to remember. This is something to assess when babies first delivered, okay, and the immediate seconds after. Are they breathing? If so, are they breathing at a sensible rate? The umbilical cord, is it pulsing? Okay, at which point, wait for white. So no rush to cut the cord, but we're keeping an eye on what the cord is doing. Is there any tone? Babies should have good tone. They should be moving around. They should be flexing and extending and should kind of fight against resistance and things like that. They should have some tone to them. They should be wriggling. They should have a good colour. So babies normally come out a bit bluish purplish, and then they pink up is the term. Very quickly they pink up after delivery. Pale white babies are not happy sights. And then a heart rate. So you're gonna have to listen with a stethoscope. There's no very reliable pulse points on a baby, so you need a stethoscope. Have a listen on the chest for the heart rate. It should be too fast to count. I've always been taught that, and that works for me. If you can count it, it's too slow. Okay, so what happens then if they're not breathing properly? So we open the airway. You can use OP airways in newborns if you've been appropriately trained. Again, that's probably going to come up on a PILS course or a neonatal life support course for those of you on FREC 4. But you can use OP airways, just bearing in mind, again, we're not putting them in 180 degrees like we would for an adult. We're going to use a tongue depressor or a small Miller 1 laryngoscope blade and just hook it over the back of the tongue without scraping along the soft palate. Give 5 inflation breaths, okay? Room air ventilation only, as a reminder. Now, this is the key point here in red. If no chest rise is observed, we fix it before we're moving on. There is absolutely no point going any further until you're getting chest rise. Now, babies will not have choked on the way out, so there is absolutely no way there could be anything lodged in their airway unless you put it there. So this is why there's no rush to use OP airways either. So babies don't need them. There's nothing structurally wrong with them generally. Okay, so you just need to ventilate a good kind of CE grip with your bag valve mask and slow ventilations. I absolutely don't want to see anyone ever kind of really squeezing hard on a BVM. It's nice slow ventilations over a couple of seconds each. Try and get some chest rise. So it's inflation breath rather than rescue breath like we would in CPR. Okay, slowly inflate the chest. Unless you're getting chest rise, there is no point moving on. Okay, so if you're not getting chest rise, it's your technique. It's not going to be the child. Okay, except in very, very, very rare circumstances. So change what you're doing and try and get some good chest rise. It might be that they just need a little wipe around the mouth. Occasionally we need to suction some meconium, some poo away from the mouth, but generally speaking, that doesn't cause too much of an issue. And the fluid in the mouth, the fluid from the birth canal and things like that, that's the factor that we want that blown into the lungs. People often think you have to suction everything out till they're completely dry. Absolutely not. Push that down into the lungs. That's surfactant. That's good for their lungs. So we need to so good ventilation. It can take a couple of breaths to get rise sometimes. Don't panic on the first 2, but by the end of the 5th, we should have had a couple of good chest rises. Okay, if you haven't, no point moving on. The next stage is to reassess the respiratory rate and the heart rates. Okay, they should start to breathe. Once you breathe for them, they normally, once they get a bit of oxygen to the brain and it all starts firing, they normally start to breathe for themselves. So if they don't, okay, we'll move on. Reassess the heart rate as well. Has the heart rate improved at all? So if there's no pulse or the pulse, so if they're still not breathing, then we're just going to continue with 5 inflation breaths until they do start to breathe, okay? But if there is no pulse, we're going to provide rescue breaths for 30 seconds, okay? Or if they're bradycardic, if the pulse is less than 60. So rescue breaths for 30 seconds, okay? And again, once every few seconds, like you would for a normal adult, maybe a little bit quicker than a normal adult. It's a baby at the end of the day, but just nice inflation breaths. Keep doing it for 30 seconds, making sure each one gives you a good chest rise. That's all the baby needs at the moment, okay? Very, very rare to need more than that at this stage, okay? Then we reassess, all right? It is only at this point, if there is still no pulse, we do our 3 to 1. So we go through 3 primary surveys effectively, don't we? So if they're not breathing at the first one, we do 5 rescue breaths. If they're still not breathing and they or they don't, sorry, if they have a pulse, then we just keep doing rescue breaths until they do start to breathe themselves. If they don't have a pulse or their pulse is bradycardic, then we breathe again for them. We keep breathing. Everything is going to be hypoxia. Everything to do with flat babies is normally because they haven't got enough oxygen. So ventilating with room air is all we're going to do up until that last stage. So after the 3rd primary survey, if they still don't have a pulse or they're still bradycardic, even though you're getting good chest rise, then we start 3 to 1. Okay, and it's dun 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 ventilate, dun 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 ventilate. It's quite quick. Okay, and reassess every 30 seconds. So heart rate, respiratory rate every 30 seconds, and get going. That's very, very rare to get to that point, and unfortunately not associated with great outcomes. So get yourself off to the nearest receiving unit. Local guidelines, please, there, folks, for the receiving units. Not all hospitals will accept a neonate resus. Okay, so make sure you know where you're going. Excellent. So then we're going to do an assessment to the newborn. Okay, so assuming everything's gone okay, we've not needed to do neonate life support. Your last question for this section is going to be around APGAR scoring. So jump back on. Here we go. Perfect. So 70150961. When should the first 2 APGAR scores be calculated? 1 and 5, 2 and 5, 5 and 10, or only at 2 minutes if greater than 7. So if the APGAR score is over 7, you only need to do it 2 minutes. 1 and 5, 2 and 5, 5 and 10, or only at 2 if they're healthy. What do we reckon? 1 and 5, 2 and 5, 1 and 5 it is. Well done. Who was quickest? Oh, Sinead, I'm disappointed. CR, who is CR? You are now in the lead. Well done. Perfect. Okie dokie. So here we go, the APGAR score. Calculating the score 1 minute and 5 minutes after birth in every single infant. Okay, even if their APGAR 1 minute is 10. What is the APGAR score? The APGAR score is looking at 5 areas. Okay, their general appearance, so their colour, whether or not they have a pulse, okay, absence, less than 100, more than 100, whether they're grimacing, okay, no response to stimulation, floppy, grimacing on suction or aggressive stimulation, crying on stimulation. Obviously, the higher, the better. What their activity is, none, some flexion of the arms and legs, active flexion against resistance. That's what you want to see. Respirations, absence, weak, irregular, and slow, or strong crying. So we get 2 points for each. They add up to a score out of 10. 10 is good, 0 is bad. Anything over 7 is anything over 7 at 1 minute is kind of normal. Obviously, the sooner they get up to 10, the better. I read when I was researching for this, I read some interesting articles around actually, even though we reassure ourselves with an APGAR score of 8 and 9, actually they are associated with long-term or more problems and needing PQ and things like that in hospitals. So just because they have a score 7, 8, 9, and we reassure ourselves that that's okay, actually sometimes those babies can develop lots of problems. So we want to see an APGAR of 10 nice and quickly, but it's done at 2 minutes and 5 minutes. And then if the score is still less than 7 at 5 minutes, we repeat it every 5 minutes until it does increase above 7, or I believe we stop at 20 minutes normally if you so you don't need to repeat it after 20 minutes. Okay, so hopefully that's been useful. The APGAR score is widely used, so and often you're asked to report it when you come into hospital. There we go. Right. Okay. For some reason that didn't appear for any of the others. So here it's now prompting me to go to Mentimeter at the right time. So it's a bonus question this evening, folks. So let's see what you're made of. So get as many of you on as possible. The bonus question tonight. Okay. 70150961. Anyone else want to join? There's now 70 of you. Okay. Right, question 8, your bonus point then for this evening. 20 seconds to answer. A pregnant patient's notes are annotated with G3P2. What does this suggest? G3P2, that she's pregnant with twins, that this is her third pregnancy, that she's had a miscarriage, that she's in the second week of her third trimester. What does G3P2 mean? Time's up. Ooh, I gotcha. So G3P2, okay, gravida and parity, okay. Gravida means how many times has this lady been pregnant. Parity is how many times has this lady given birth to a baby over 24 weeks, okay. The fact that she has been pregnant 3 times and only produced or only given birth to 2 live babies. Unfortunately, that does mean that she has at some stage had a miscarriage. Okay, G3P2 does not include the current pregnancy. That is always the spurious one. So a patient that's pregnant, G3P2 means she has had a miscarriage at some stage. Grown 3, produced 2. I always remember it as grow and produce. So you grow them and produce them. If you don't, if stillborn is unfortunately, or a miscarriage, should I say? Sorry, is so a stillborn over 24 weeks is still counted as parity. So you might see a G3P3 and they've had a stillborn, but if you've given birth before 24 weeks, i.e. a late miscarriage, then it will be annotated G3P2 in this situation. So she's had two infants born over 24 weeks, whether or not they're live. Okay. Hopefully that's been helpful to you folks. You'll see G3 or you'll see G's and P's on everyone's patient's notes. So when you're dealing with maternity cases. So good. So we've run over slightly, but that does come to the end of this evening's session. Had a really good turnout tonight. So thank you for coming along. I do hope it's been useful. I've not seen any questions come up in the chat. So I hope that means that I've answered any you have got, but do feel free to ask away now or drop us an email afterwards. We're back next Wednesday. As I say, we're sticking with Wednesday nights for the moment for our schedule. It's just going to work a lot better. So at the new time of 7:30. So we'll be back next Wednesday, the 6th at 7:30, where we're going to be talking about some patient assessment techniques, just to help those of you that are doing some CPD in that area. So do please feel free to come along to that. Registration should be open on our Facebook. If it's not, I'll make sure it is by the end of tonight. No, it's a different link, John. So have a look on our Facebook page and our website. Certainly tomorrow morning, if you look there, the links will all be up. So register again through Zoom. We hope you join us next week. As always, if you've enjoyed tonight, then please do leave us a review. Facebook, Trustpilot or Google reviews are really useful. And we do have a certificate for you. So if you don't mind, just bear with me a second. I'm going to copy the link for that and come back in. Okay. So let me just pop in the chat box now, folks, is the link to claim your free certificate for this evening. So click on that now, fill out the feedback form, and then it should generate a PDF certificate for you. So hopefully that's useful. If you miss the link, don't worry, it will go up on our Facebook page tomorrow. It will also go up on our website in the next day or two. All right, so hopefully that's been useful for you. As I say, we hope to see you next week or of course, face-to-face on one of our upcoming courses. It'd be really good to have you. And as I say, please do take the time to leave us a review if you've enjoyed tonight. It really does help us get people onto our courses and claim your certificate. Any questions, folks? You're more than welcome. Thank you, everyone, for coming. I look forward to seeing you next week. So the link is in the chat. So do just have a click on that. It's gone up a little bit now. So, as I say, if you do miss it, don't worry. It'll go up on Facebook and it will go up on our website in the next couple of days. I'll take any questions.